Good evening, ladies and gentlemen. Welcome to this webinar on practical usage of NOACs with focus on dabigatran. And we are also going to focus on the current recommendations of the European Heart Rhythm Association, February 2018. With us, our honored speaker is Dr. David Fitchett, and I know it's morning in Toronto, and I had the fortune of meeting Dr. David Fitchett last month in Delhi, and we had some great programs. Dr. Fitchett comes from St. Michael Hospital, Toronto. He's professor of medicine and a great researcher and accomplished clinician. And many of you know that he has been one of the principal investigators of EMPA-REG outcome trial, and of course recently a late-breaking trial which was presented in the American Heart Association called EMPA-HEART study. And Dr. Fitchett is going to take us through the practical usage of NOACs in light of the guidelines of the European Heart Rhythm Association 2018, and the focus would be on dabigatran. Let me shoot the question. The first question somebody asked me, why not use in a mechanical prosthetic valve? Why not use NOACs in a mechanical prosthetic valve?
So there is one trial, and my memory escapes me with which agent, which showed that there was an increased cardiovascular event rate with the NOAC compared to warfarin. So because of that one single trial, nobody's really prepared to do another trial. It may be that the patients were underdosed, but this trial has stopped any use of NOACs with mechanical valves.
Yeah, so this was a realigned study. The study was realigned with dabigatran, and there was cardiovascular events.
So that was with the dabigatran?
Yeah, the dabigatran, realigned.
Yeah.
So in the same vein, why not use in a mitral stenosis? Same reason or some different reason?
I don't know of any trial with a NOAC in severe mitral stenosis. Patients with mitral stenosis are at particularly high risk of emboli. They've usually got thrombus in their left atrial appendage. So I think that people are, the guideline committees are reluctant to recommend a new agent which has not been tried in a high embolic situation. As I say, these patients have thrombus. There's no question. I mean, you remember the days of mitral valvotomy when they used to cut the atrial appendage. I can remember one of my surgical trainers in my medical school days saying, you snip the end of the atrial appendage, you don't touch it. And then you allow the thrombus to come out of the atrial appendage before you do anything else. And he said it was very frequent that you saw thrombus in the left atrial appendage. So it's a high embolic risk situation, which there is benefit with warfarin, but there's been no trial that I know of to compare warfarin in that situation.
So, Dr. Fitchett, I think the reason probably is a small experimental study, which I don't know when was done and who did it. They tried to actually measure the thrombin levels in atrial fibrillation without mitral stenosis and patients with atrial fibrillation with rheumatic mitral stenosis. And it so appeared that the circulating thrombin levels were 6 times more in those who had rheumatic mitral stenosis. And one of the reasons they thought was they wouldn't be able to give that much of a dose to take care of the thrombin, and the bleeding will be unacceptable. I thought that was one of the ways.
You may be right. It sounds a very reasonable explanation. I'm not aware of that study. So, no, that's a very good point. But I'm not sure why their thrombin levels should be so high. Is that because they've got active thrombosis, perhaps? But for the same reasons as I said.
Yeah, there could be. So there is another question, and it says, can the drug be used for prophylaxis of deep vein thrombosis?
Oh, very much so. Yeah, all the agents are indicated for that purpose. Different doses.
Yeah. So another question is, how long would you give dabigatran for treatment of deep vein thrombosis?
Well, it depends on why the deep vein thrombosis occurred. If there's a provocative situation, a post-operative, or the patient has been on a long journey or something, there's a clear cause, then you might treat for 6 months. But if the patient has an unprovoked one, or one associated with a malignancy, for example, you might treat indefinitely.
So the next question is, can you use dabigatran in patients with cancer? Can you use it? Do we have any data?
I'm unaware of any. I'm a cardiologist. My knowledge of deep venous cirrhosis prophylaxis and treatment is somewhat limited. Unless there's an increased bleeding risk, I mean, for the patient who has untreated bowel cancer, I'd be somewhat reluctant. But if the cancer is treated and not associated with increased bleeding risk, I don't see why we shouldn't use it. Can you see any reason why not, unless there's an increased bleeding risk?
So it so happens that the ACCP guidelines say that use only low molecular weight heparin for treatment of DVT and for prevention of DVT in cancer patients. The data, these people have said that the only thing which can be used is LMWH, nothing else.
Yeah, or oral or warfarin some people
Warfarin
have given.
Can be used,
but there is a study in the subgroup, in a RISE Total trial, the Apexaban, there were a few number of patients with malignancy where they have tried this drug, and when they found the results, but they were not different. It was same. But so far the guidelines are still not favoring NOACs for the management of atrial fibrillation in patients with malignancy. Probably in future, maybe we will be in a position when data will be more available. Probably off-label people are writing this drug, and probably in future we'll be able to answer this question.
The COMPASS actually analysis which was presented, this ESC showed that bleeding is far more in those people who have occult malignancy.
Yes. When
you use DOACs or NOACs, then the bleeding is much more compared to low molecular weight heparin, in fact.
But that's the same with any agent, which, for example, antiplatelet drugs may well, if you've got occult malignancy, it may well find that malignancy. So the diagnosis comes out earlier. So I think that's true with any agent which increases the risk of bleeding. So I'm not sure that's surprising.
Yeah, probably after the availability of antidote, maybe that it could be coming to guidelines.
So Dr. Fisher, there is another question to you, and that is, it says that would you be comfortable using dabigatran in patients with degenerative mitral stenosis?
Sorry?
Degenerative mitral stenosis. Would you be comfortable using dabigatran in patients with degenerative mitral stenosis?
What's the word before mitral stenosis? I don't understand the
mitral annular calcification. MAC.
Degenerative. Okay, sorry. Somebody who has. I understand now. Somebody who has MAC and has a calcified mitral valve.
Yeah.
I don't know. I honestly don't know. I'm sure there's been very few patients with that in any clinical trial. I mean, the issue with rheumatic mitral stenosis is that you're not just dealing with an obstructed valve, you're dealing with a diseased left atrium, which is highly thrombotic, and this is why there's this increased thrombotic and embolic risk in rheumatic mitral stenosis. I don't know. I mean, I suspect you would be reasonable to use, but it would be experimental. I don't know whether there's any experience.
Okay, the other, you are actually referring to the apical aneurysm hypertrophic cardiomyopathy. But the question is, can you use dabigatran or any other NOAC in a patient who has left ventricle thrombus? In sinus.
So somebody who's had a myocardial infarction has an apical aneurysm and a thrombus.
Yeah.
I mean, I think you could. There aren't too many studies with warfarin and post-infarction. There are some observational studies which have suggested the thrombi get smaller, but I'm not aware of any clinical trial trying warfarin against no warfarin in that situation. I suspect you could use it. And it wouldn't be unreasonable. I'm not sure that the guidelines have told me much about that situation. I haven't seen it. There's certainly no mention of ventricular aneurysms in the European Arrhythmia Association guidelines. There's no mention at all.
But do you use it offline for LV thrombi?
For ventricular thrombi?
Yeah.
In the short term, yes. But if it's a long-term treatment, for example, as I said, the two people that I've had recently with apical hypertrophic cardiomyopathy and emboli, I've tended to use warfarin. We're dealing with situations where we really don't know. We've been using warfarin for years for ventricular thrombi. So I think that we will. I suspect we will get. Sorry, you wanted to say?
Yes. I have got one question. There is a patient of mine whom, when started dabigatran for atrial fibrillation, his GFR was around 45 ml, and on follow-up over 1.5 years, when he showed a deterioration in his renal function, now his GFR is 25. Shall I stop this drug and switch over to the other drug as per the guideline, or shall we continue with that drug?
I think that the patient is clearly is not having any problem. It comes down to medical legal questions. If this patient next week had an intracerebral bleed, what would your liability be? I don't know. I think we probably should follow what the labeling suggests, mainly for medical legal purposes rather than necessarily in the patient's best interest. I don't know. I mean, I'd appreciate these sorts of questions are questions which you people have views on. I'd appreciate your view on it. What do you think?
Yes, I thought I will go with the guidelines and I stopped the drug and switched over to Apixaban. This is why I thought, let me say, well, as you say, rightly, legally, we will be liable for that if the patient bleeds tomorrow.
Absolutely. Yeah, so I
but
think
the only thing is, in India, we have now 75 milligram available. The US guideline says we can use in lower GFR 75 twice a day. But in India, we are in the our DCGI do not allow. They say only up to 110 for the.
We don't have 75 either in Canada. Now, I think what you did is probably the correct thing, is to swap over to another agent. And the patient, I'm sure the patient would have done very well staying on the dabigatran. You could have reduced it to 110, of course. 110 is available.
Yes.
Dr. Richard, there is another question. Somebody who needs dabigatran also has associated thrombocytopenia, a platelet count of less than 50,000. Would you be comfortable using dabigatran in such a patient? Let's say this patient has immune thrombocytopenia, also has atrial fibrillation. How comfortable you would be using dabigatran?
I don't think the thrombocytopenia will protect him from embolic stroke. So I think he needs an anticoagulant. I think that he's having no spontaneous bleeding, I presume.
But you did show EHRA guidelines where thrombocytopenia less than 50,000 count was a relative contraindication.
It certainly is. It's certainly a relative contraindication. But if the patient has got a high thromboembolic risk from atrial fibrillation, then I don't think you can do nothing unless the patient is, I mean, if they've got thrombocytopenia and is having active bleeding or has had bleeding episodes, then you probably can't do anything. But if they've got a platelet count of 50,000 and have no spontaneous bleeding at all, then it would not be unreasonable to use a low dose of a NOAC. But
Okay, question.
you know, just think of the patient. The patient has diabetes, he has hypertension, he's 69 years old, and he's got atrial fibrillation and a platelet count of 50,000. This guy's at high risk of thromboembolic stroke. You've got to do something. You can't just leave. His platelet count of 50,000 is not going to prevent him from having thromboembolic stroke. So, yes, it's a relative contraindication, but there again, you've got to have a conversation with the patient. You've got to discuss the benefits and the risks. In that situation, and I must say I haven't encountered it, I would probably recommend a low dose of a NOAC.
Great. So here's another question. It's a little provocative. It says, since the compass says you can use rivaroxaban low dose with aspirin in stable coronary artery disease, can I use dabigatran 75 mg twice a day with aspirin in stable coronary artery disease?
You could, yes. The clinical trial hasn't been done, so I don't know. I mean, it's likely to have the same benefit.
One more question. Can I ask one question?
Yeah, please.
Hi. So there is a patient of mine who has undergone PCI for STMI, and he's on ticagrelor and aspirin, and after three weeks he developed atrial fibrillation. So we have to put him on anticoagulant now. Now, shall I withdraw the ticagrelor or shall I continue with the ticagrelor in this situation, an ACS situation where I have to put him on dabigatran?
How long after the ACS?
3 weeks.
I would probably stop the aspirin. Okay, so does he have any high bleeding risk?
Well, no. He doesn't have high bleeding risk. And the studies, both Pioneer and the Reduel, have only very small number of patients on ticagrelor. But when we looked into the subgroup analysis, where they have used ticagrelor versus clopidogrel, the ticagrelor group had more bleedings in both the trials, in small number of patients, of course. And the guidelines do not favor that. So shall we stop ticagrelor or shall we stop aspirin?
The guidelines certainly a few years ago would have recommended you swap over to clopidogrel if you're going to use triple therapy. But you're right. I mean, the recent studies don't suggest that there's increased bleeding of the patients with ticagrelor. So I would probably I definitely initiate a NOAC. I would, and dabigatran would be a reasonable choice. The only question is whether you stop the aspirin. I think that would be the important thing. I would continue the ticagrelor, I think. And depending on the patient, I would probably continue the aspirin. If the patient is not a high bleeding risk, I would continue the aspirin for a further month or two, and then stop the aspirin.
My point is that ticagrelor is a competitor of P-glycoprotein. And this increases the area under... Yeah, it increases the area under curve of dabigatran by as much as 62%. And I am sure that the chances of bleeding will be more than what can be done with clopidogrel. I will be uncomfortable continuing with ticagrelor. I would much rather...
But the new guidelines do not favor clopidogrel.
Yeah.
The new guidelines do not allow clopidogrel in ACS patient now with PCI. The post-PCI ACS patient, clopidogrel is out.
In fact, in the ACS situation, the guidelines say that you use ticagrelor or prasugrel and aspirin and all the three for the first 3 months.
Not ticagrelor.
And it does not talk of clopidogrel at all at that situation.
So I think the Augustus trial, which we are also part of that study, and Entrust trial for using the apixaban, where actually true comparison between the 3 drugs versus 3 drugs in two factorial ways has been done. I think probably that will answer more questions.
I don't know which guidelines you are talking about.
This is-
but I am very clear.
ACC.
I am talking about, yes, 2016 guidelines. were
They
very
do not.
clear.
No, that's not. We talk
The
about 2018.
guidelines are only for STEMI. They are not for
STEMI.
non-STEMI.
I'm talking about STEMI.
Okay.
ACS and
But how can there be so much a difference between STEMI and non-STEMI?
That's right.
The guidelines say so. That is the problem.
No, the guidelines only say ticagrelor to be preferred over clopidogrel.
No. The word does not say no
It
that.
says only 2, ticagrelor or prasugrel.
Because there is no mortality reduction with clopidogrel, only reduction of microinfarction and stroke. So they have the guidelines straight was struck out that area now.
Clopidogrel has been stuck out.
Struck out. So that's the reason
So
probably.
only by the Europeans. Why?
Then ACC.
No, not by
Yes,
no.
this is ACC.
So there is a potential solution to this.
Yeah.
So when you have agents which are PGP competitors, pre-glycoprotein competitors, you can get around this by making sure the dosing is several hours apart. So you can give your ticagrelor and then give your apixaban 3 or 4 hours later. And that apparently the interaction is reduced. I was just looking at what the recommendations are in the certainly in the new guidelines from the Arrhythmia Association. There is no warning there at all about the interaction. Yes, there's a 25% increase in about a 25% increase in level, and they recommend giving loading doses 2 hours after the dabigatran. So the dabigatran first, and then the ticagrelor second. So that may be one way of getting around it, but that's the guide. That's what's in the current guidelines.
Regarding the drug interaction, we face a big problem in our country because a lot of patients are getting anti-tubercular treatment. They get tuberculosis, they get
Right.
anti-tubercular treatment.
Right.
Rifampicin causes big problem in patients with vitamin K antagonists like warfarin or acetrom. And at the same time, this also shows all the drugs, all NOACs are also, the levels are reduced by significantly by 60 to 70%. Which drug to use now? Shall we use acetrom or shall we use NOAC?
And also with the anticonvulsant. I've had
Yeah,
practical
yeah,
problem.
practical problem.
Patient got a seizure after starting.
But I think here you would have to monitor the coagulation factors regardless of the cost and regardless of inconvenience. But there is no other way.
No, other thing is that acetrom in higher doses, you can use
Yeah.
that. That is the
So
only
I-
answer. Easy.
Yeah.
So what to do? Whether to use NOACs or
rifampicin has an effect on all the NOACs. It reduces the efficacy of the drug, so you're going to have an increased risk of thromboembolism if you use a combination of NOAC and rifampicin. I mean, in that situation, you may well be forced to use warfarin. I don't think you're going to double up the dose of the NOAC to get over the rifampicin effect. So,
But,
I mean,
we face
you're
problem
right.
with warfarin also.
Sorry?
We also face problem with warfarin. Patient was
I'm
controlling INR between 2 and 3 with 5 milligram of warfarin. I started ATT. Third day his INR was 1.1.
No, I'm sure it's not easy, but at least you are measuring something. So, just one bit. Yeah, I mean, looking at the figures here from the guidelines, rifampicin reduces the efficacy of dabigatran, all of them, by about 50%. So, yeah, it's a very important effect. We certainly shouldn't ignore that. But you know, at least with warfarin, you're measuring something. With the NOACs, a little more difficult. You know, if you're going to use the Bigatran, you've got to use this diluted thrombin time or the Ecarin time, and that I don't know whether those are readily available.
Well, you know, there is a distinct advantage of warfarin. You can increase the dosages depending on the PT time. But, you know, you don't have any measure, and there's no evidence that how you increase the dabigatran dose with the diluted thrombin time, if it is available.
I would definitely not do that. But I agree with you. I think that's the advantage of using warfarin in this situation. You are at least measuring something. Some people need quite large doses, and I suspect with the rifaximin you're going to need larger doses. But at least you're measuring something which relates to the bleeding risk.
I think the best answer will be to stop the rifampicin and give some alternative antitubercular treatment.
Well, I agree. That's probably the best solution.
So, Dr. Fisher, there is another question for you, and that is, it is asking you, if somebody is getting a recurrent cerebrovascular accident and patient is in sinus rhythm, would you use the Dabigatran? No atrial fibrillation.
Okay, so my first question. Okay, so somebody who's having multiple cerebral events. First of all, what does the CT scan or the MRI show? Are these cerebral infarcts compatible with embolic events? Has he got multiple cortical infarcts? That's the first question. Because people can have multiple strokes from other things than atrial fibrillation. That's the first question. The second question is, how well have you looked for atrial fibrillation in this patient? The minimum is two-week recordings. Have you done that? Because, you know, so the point is, yes, you could just give him a NOAC and see what happens, but you are exposing him to bleeding risks. And if it's not recurrent, if it's not paroxysmal atrial fibrillation, you might not be doing him any good.
So the current AHA guidelines support 30 days of monitoring. It still makes life more difficult. 30 days.
How long? 30 days. That's what I said.
That's exactly 30 days of monitoring.
So I have one patient.
Two 14-day periods.
Yeah. So I have a patient. She's 69-year-old female with hypertension, diabetes, and she had stroke. First, only one stroke, and now I did a 28 days external loop recording. All 28 days, I found same finding. There were 9 to 15 episodes of atrial fibrillation less than 3 or 4 seconds or 5 seconds. There were none of them were more than 30 seconds. Now, can we correlate that? Shall we start dabigatran in such situation? Because the guideline says it has to be minimum 30 seconds at least, or some people say 6 minutes.
I agree. I mean, short bouts like that are almost certainly not responsible, and 30 seconds is unlikely to be responsible. But if you're getting 30 seconds, I guess the chances of having an hour or two are that much greater, and that's why the threshold in somebody who has had a stroke which is compatible with an embolic stroke, if you find 30 seconds, you're going to treat it. But 2 or 3 seconds, I would not treat.
So Dr. Lip calls it FDAS, atrial fibrillation detected after stroke. And he says it is a heterogeneous group. There are cardiogenic causes and there are neurogenic causes. And neurogenic causes for atrial fibrillation is unlikely that the NOACs would work in that situation. So he says that FDAS is one area, and it's not uncommon. He has found that 23% of the patients who have suffered from stroke eventually show FDAS. And the point is how to treat them. Can we use the same guidelines? We have no answer, in fact. And he says there is a role of insula in producing atrial fibrillation through the autonomic dysfunction, and that can persist for months after stroke. So then the neurogenic cause of atrial fibrillation.
So yeah, this is a huge problem. And which came first, the stroke or the atrial fibrillation? And yeah, it's a very difficult situation. But the incidence of unrecognized atrial fibrillation is very high. I think that if somebody is having atrial fibrillation, but again, you need to make sure that if they clearly have got a caudate nucleus stroke, typical vascular stroke, then you're not going to, if the MRI, the CT suggests the location is in the cortex, multiple cortical strokes, then of course, then you're going to treat it more. So you need to know more about the stroke.
So would you be using NOACs in antiphospholipid antibody syndrome?
I don't know. I mean, I have very little experience in treating that condition. I've had probably half a dozen patients in my almost 50 years of practice.
So it's interesting. The antiphospholipid antibody syndrome is actually a reasonably common condition. And mostly, of course, our obstetrician friends see when they see fetal loss once or recurrent fetal loss.
Right.
And most of these cases are actually antiphospholipid antibody syndrome. They also have, of course, more chance of DVT, arterial thrombi. So the question actually has been asked to me by obstetrician repeatedly, can we use NOACs in these patients? Especially when the ladies are not pregnant.
So is there any reason not to use them?
I don't know.
There is a reason. There is a reason. In fact, I have one patient and we did discuss about it. There is no evidence to suggest that NOACs work in antiphospholipid syndrome. Here we have a definite mechanism of atrial fibrillation and we have trials for that. And it so happened, a friend of mine, his wife, she's suffering from SLE and has an antiphospholipid syndrome. She had stroke 3 times. She's herself a doctor in US. And what was recommended to her was to be just on warfarin rather than NOACs. I read about another patient of mine and I got into detail. So it is again, there is no labeled indication of using NOACs.
So genetic causes of hypercoagulable state. We don't have enough data.
We don't have enough data.
I have actually 3 females who are coming with recurrent painful proximal vein thrombosis. I put all of them on dabigatran and for a variable period of 3 to 9 months they are free of recurrent thrombosis. So I thought I'll raise that.
But if that situation comes during pregnancy?
Now you can't use it in pregnancy.
Yes, that's the thing.
You can't use even warfarin. You have to go on low molecular.
But warfarin,
yes, you can use the second trimester.
I want to ask sir one question. I want to ask one question, sir. The ACC guidelines recommend that when you are giving 3 drugs, like you're giving 2 antiplatelet and you're giving 1 NOAC, then preferably you should use proton pump inhibitor. So it is written black and white that you use.
Yes.
In our day-to-day practice in India, we use quite a lot of proton pump inhibitors. So do you also use or do you justify the use in patients who are on 1 antiplatelet and also on NOAC, or you would not like to use?
In general, I only use the PPI in people who are on triple therapy. So many people are on dual. I'm not routinely using a PPI in people on dual antiplatelet therapy. Triple, yes.
So in triple therapy, which NOACs would you prefer out of all the 3? Because the most robust data is with the dabigatran. So would your preference in triple therapy would be which NOACs?
My experience has been with I have no experience with edoxaban, but I have experience with dabigatran, with rivaroxaban, and with apixaban. I don't see any good reason to choose between the 3. I mean, all 3 would be effective in that situation. Interesting are the comments about the glycoprotein, P-glycoprotein, but again, the guidelines again recommend that we separate the timing of the treatment. So give the for example, dabigatran before you give the ticagrelor. So I don't have any strong feeling. So do you have any reasons for choosing one over the other?
So the thing is that in rivaroxaban, the pioneer used 15 milligram, which is not the usual dose of prevention of AF. So that is a challenge which is there. And so shall we use 15 or 20?
I would probably use 20. And I would probably also, in my practice until recently, has been to not use ticagrelor in this situation because of the increased bleeding risk compared to clopidogrel. But the recent trials have not shown any, haven't borne that out. So I'm a little bit confused of what the optimal is now. But my practice in the past has been any of the oral anticoagulants with clopidogrel rather than ticagrelor.
Last question, Dr. Fitchett. The question is the role of NOACs in atrial fibrillation undergoing cardioversion, electric cardioversion. Before there's good data to show that they work. I mean, they reduce thromboembolic stroke. I think the period of pre-treatment prior to cardioversion is the same as we have used with warfarin. The only thing with warfarin is that we usually required that they had the INR in the therapeutic range for a month prior to the cardioversion. With the new oral anticoagulants, we just require that they are on one of the new oral anticoagulants for a minimum of a month prior to the cardioversion. But I don't discontinue them for the cardioversion, and I don't stop the oral anticoagulation after cardioversion in most patients. If there's an indication prior to cardioversion, then there's usually an indication afterwards, except in a young patient. In a young patient who has no increased risk of thromboembolism, then I will stop it after 6 months. Thank you, a wonderful interaction. Thank you very much.
Sorry, does that answer your question about cardioversion?
I think we know there is paucity of data in this area, and you did say that you would continue the NOACs in patients who are undergoing cardioversion, but you are saying that we don't have really data whether they protect against the formation of thrombi actually in these people. I mean, they have to prevent thromboembolism, because the biggest risk of cardioversion, electrical cardioversion, is thromboembolism.
Absolutely right. But there are now several studies of the use of NOACs in cardioversion, and all we can say is that they look as effective as warfarin in those studies. But patients remain at risk of thromboemboli after cardioversion, so I think we have to be very sensitive about not stopping them in most patients, because they have a high risk of recurrence. And also we recognize that after cardioversion, the atrium is paralyzed for quite some time, and so there's still a high risk of thromboemboli even in a young person for a period. So I usually will reassess at something like 4 to 6 months after cardioversion in a young patient, and then make a decision about whether we stop the anticoagulant then. But in a patient who has an indication for anticoagulation, an older patient, a patient with hypertension or diabetes, I will usually continue even though they've been cardioverted.
Thank you. That makes a lot of sense actually. I think we would do the same thing. Yes. If there are no more questions, I think thank you, Dr. Fitchett, very much. And it has been a wonderful session and wonderful interaction. And for us, it has been a great source of learning and sharing some of the thoughts with you. And of course, I think we have learned there is a lot of knowledge gap with regard to NOACs in multiple situations. Like you said about LV thrombi, apical aneurysm, hypertrophic cardiomyopathy, cardioversion, and somebody said about STEMI and using ticagrelor and NOACs. But I think with passage of time, we will probably learn more about these things. Thank you very much. Have a good day.
Well, thank you as well. I've learned a lot in this interaction. I mean, I'm a humble cardiologist. You guys are cardiologists, but they're also, I think, very good general physicians as well. You're probably seeing more deep venous thromboses than I see, so you're much more accustomed to seeing people with lupus and phospholipid syndromes, for example. Anyway, I've learned a huge amount. Thank you very much. I look forward to seeing you again in India sometime in the future.
Thank you.
Thank you.